Good evening and welcome to the SWESEM Learning webinar on traumatic cardiac arrest and bullet triage. I just wanted to speak a little bit about our project. We are a group of doctors, of physicians. Some of us belong to the SWESEM, if you know, it's the Swedish Society of Emergency Medicine, and other external emergency physicians that work together now to make SWESEM Learning a group. It's an e-learning platform for the Swedish Society of Emergency Medicine, and it serves as a hub for high-quality, evidence-based educational content tailored to the emergency medicine professionals, both in Sweden and beyond. And our aim is to empower the clinicians with up-to-date knowledge through an open access resources, including webinars, case discussion podcast, and peer-reviewed literature, curated by experts and frontline practitioners. So in the recent years, Sweden has faced an alarming rises in gun violence, often linked to escalating gangs conflicts. If you guys remember, like the Örebro school shooting that happens recently, when a 35 years old former student opened fire and killed 10 people and injuring 6 before apparently taking his own life. The other tragedy as well, like the Uppsala, like in the hair salon shooting, also on the 29th of April, when a masked gunman killed 3 young people between the age of 15 and 20. So from this fatal shooting, we saw like the need to increase our knowledge and the experiences about the trauma and the traumatic cardiac arrest. So when we started to think about the topic, I thought of two famous pioneers in the emergency medicine. They're well famous in trauma. And as maybe all of you know, our friend from the US, Qasim, and Rasmus Strandmark. So it's a true privilege for us to introduce our first speaker, Dr. Qasim, a global leader in trauma and critical care. He is an accomplished emergency and critical care physician based at the University of Pennsylvania. He has a very, very big experiences in the US, UK, and Pakistan. He also works as an EMS physician and a specialist in trauma and surgical critical care at the Shock Trauma Center in Baltimore, Maryland. So feel free to post, for the audience, feel free to post your questions in the Zoom question and answer box at any time during the session. I'll collect them and present them to the speakers after each talk. So now let's begin. Dr. Qasim, the screen is yours.
Yeah, thank you very much. I'll just share my screen, make sure that you can all see it. Can you see it?
Yes.
All right, great. So thanks so much, Mohammed, for the invitation. I really appreciate it. I'd have a chance to talk a little bit about my practice. I work in Philadelphia, as Mohammed said. I work in the emergency department as well as I'm a critical care physician, and I also do some pre-hospital care. And I live here in Philadelphia. Hopefully, some of you have had a chance to visit. It's a beautiful city. Kind of partway between New York City and DC, so very easy to get to from Sweden for sure. And you may remember it if you've ever seen one of the Rocky movies. You'll see that Rocky was done here in Philadelphia, and we have a statue to commemorate Rocky and Sylvester Stallone. So that's our claim to fame here. But Philadelphia is a pretty populous city, so we're the sixth most populous city in the United States. So during our regular kind of census is about 1.5 million people. But during the week, because of people who come to work as well as visitors, we get around 3 million people during the day and during the weekdays. And so our trauma system is really set up with 4 adult level 1 trauma centers, probably a little bit too much for our city, but still that's what we have, as well as 2 pediatric trauma centers. So between them, we see all the trauma in the city. Our center is University of Pennsylvania, which is covering kind of the south and west of Philadelphia. And we see about 3,000 major trauma activations a year. So pretty significant volume for our trauma center, and about 30% of our patient population is penetrating. So much larger than I think several of the centers even in the United States. This is what our trauma room looks like. So we revamped this in about 10 years ago. We have 5 trauma bays. Each of the bays is set up in a similar fashion. So you have equipment for your airway, including video laryngoscopy. We have our monitor, ultrasound equipment. We set up trays to do procedures like chest tube or thoracotomy, as well as IV access. We have a space for our nurse to document what we're doing. And there's some additional equipment at the back as well, just in case you need to do things like central line or surgical airways. So those equipment are in the back there. And then we have a timer just to keep us on track and make sure we're not wasting too much time in the resuscitation room when a person needs to go to the operating room. An additional thing that we have is we have a blood fridge. So we have blood available to us right in the emergency department. If a patient needs blood, they can get it right away. And another interesting thing that perhaps not many places have is we video record all of our trauma resuscitation. So we actually have the opportunity to look at and review our trauma resuscitations, both from an educational aspect. We do usually a monthly review of our resuscitations, looking at how our teams are working, sometimes for interesting cases. And in addition, it also allows us to do research. So we use the video to do some of our research projects as well. So this is kind of typically what our trauma resuscitation would be looking like with a patient. So usually our trauma surgeon will be the trauma team leader, but in their absence, the emergency medicine consultant or attending will be there. Airway is always managed by emergency medicine, so we'll be the primary person that's doing there. It's very rare for anesthesia to come down to manage our trauma airways. One of our residents is usually providing the primary survey. They can be from emergency medicine or surgery. And we're helped out by a couple of nurses as well as trauma technicians so that they can do the procedure like getting the clothes off, getting some IV access. And then our documenter is really kind of separate from the whole process so they can keep an eye on everything and make sure that they denote everything in the right time for our resuscitations. So we've all gone through the pandemic, but unfortunately, in the United States, we have this epidemic of gun violence, and Philadelphia is no stranger to gun violence for sure. These are just the statistics over the last several years of the number of shootings that have happened. So you can see a huge number. Just as an example, this is my trauma pager for just a typical overnight in the summer, where you can see just in a few hours we've had 5 or 6 shooting victims come in. So it can get pretty busy, especially over the summer. But sadly, as Mohammed said, you guys are seeing problems like this. And Örebro in particular, when I saw this headline, I felt very sad because I've been to Örebro a few times as part of the EVTM conference. And you guys might know Dr. Tal Horer. He's a friend of mine who has invited me to Örebro a few times. So I knew that city very well. But even more recently, we heard about this shooting in Austria where unfortunately, all these people ended up being killed. And so, even though you're not seeing it on the scale that we are, thankfully, still it's becoming an increasingly frequent issue in European countries as well. And so, we do things well that we see often. Thankfully, you're not seeing shootings often, but that means that sometimes you might have challenges or even be wondering, exactly what to do differently for shooting victims. And so hopefully we'll talk a little bit about that with how to manage these in the emergency department. We'll talk kind of broadly about 3 things: about ballistics and whether they matter in civilian care, which early interventions can change outcomes, and do all of these patients need to go for surgery. So ballistics is an interesting question in civilian care because we always kind of think about, these different, if you've seen them on TV, 45 caliber handgun or a 9 millimeter handgun has been used for the shooting. Does it really matter? And our politicians are always making these big claims, oh, it's a war zone here, everybody's shooting each other. And thankfully, you can take this with a grain of salt, because what you're not seeing in the streets of Philadelphia are the weapons that people use in wars, like is happening in Ukraine and things like that right now. Typically, the shootings that are happening in our city happen because people are using these handguns. And handguns are low velocity weapons, which really becomes important in the management approach to these. So the velocity is really what's important, as opposed to the particular caliber of the bullet being fired. And so if you look at what happens when a bullet strikes soft tissue, so the bullet makes primarily what's called a permanent cavity, and that's because the bullet's going through the tissue and causing damage. And so a 9 millimeter bullet will form a 9 millimeter permanent cavity. But what's more important and what's unique for penetrating trauma from guns is that there is this temporary cavity that's made, and that is because of a dissipation of energy that the bullet gives off as it goes through soft tissue and changes into different interfaces as it moves across. And in addition, the bullet can sometimes spin around as it kind of goes through the tissue, and so that can also cause some damage. But if you remember your physics, you'll remember that the energy dissipated is primarily dependent on the velocity of the object, and so the velocity of that bullet really makes a difference. So if you take a typical handgun, you can see that certainly it'll cause damage, but overall the size of that permanent and temporary cavity is not very big. But when you look at the weapons that are used in some of these mass shootings, you'll see these type of rifles or AR-15 type guns that are typically kind of used. These are much higher velocity weapons. And so they will cause a much bigger permanent as well as temporary cavity. And that's what really causes the damage and the severe damage to the organs that as compared to some handgun injuries. And so really need to be mindful of that. Just as another example, this is a 38 caliber handgun, what the size of the temporary cavity might be, and this is the equivalent of a rifle. And so you can see how different the size is of that temporary cavity that causes most of the damage as the bullet goes through tissue. So, even though a lot of times these weapons might not be used in, say, in the European shootings, what is important is that you might see victims or patients because the police that respond might be using the rifles. And so, if you look, for example, with your Swedish kind of tactical police teams, they will often use rifles to subdue the subject who's kind of causing the threat. And so if that person ends up coming to your hospital, they might have suffered a gunshot wound from a higher velocity weapon. The type of bullet can also sometimes affect injury patterns. So you might have heard of the term full metal jacket. It describes this bullet as well as a very good film if you haven't seen it as well. So the full metal jacket refers to the copper casing around the bullet. And that's opposed to the hollow point bullet, which is designed to deform on entry. So you can see the tip is hollow there and it splits apart and deforms as it goes into the body. So a full metal jacket bullet will go pretty much through the person. So it'll go in one side, out the other, and doesn't cause as much damage as it goes through. But the hollow point will expand and cause a lot more of that temporary cavity to form and can cause a lot more significant damage to occur to the person. We've seen these RIP bullets also in Philadelphia. So RIP doesn't stand for rest in peace. It stands for this radically invasive projectile. And these are a real challenge for us because as they kind of leave the gun, the little projectiles at the end there, they actually move off in different directions. And so they can cause injury to a number of different organs. And a couple of x-rays for a few patients that we had. This was a patient who was shot in the left side of their chest. You can see the bullets kind of split apart and gone in multiple different directions, even one below the diaphragm. And this person was shot in the leg and ended up having bullet parts go to various different aspects And so even though the wound might be in one particular area of the body, it could cause significant amount of damage to multiple organs within that space. Shotguns can also cause damage, and I think perhaps farmers and things in Sweden might have these shotguns to deal with some vermin or something like that. So these might be something that you see. The shotguns are designed to have a number of these pellets in their in the bullet. And so they are a very high energy weapon and high velocity weapon, but the energy dissipates very quickly as it gets further away from the shotgun itself. So as you get further apart, you get a bigger spread of those and you get a lower velocity. So the further away you are, the more likely you are to be less injured. So as a few examples, this person was shot pretty close. You can see the tight grouping of the various shot there. And if you look at the X-ray, you can see multiple injuries that are caused by this, even some going across the midline. And if, interestingly, if some of these enter the vasculature, they can actually embolize and go to different parts of the body. So you need to be mindful of that as well. This person, even though it looks like they were shot pretty close, were actually pretty superficial. So they were further away, and you can see that the penetration isn't anywhere near what happened with the other person. This was a real unfortunate guy. He was just having fun playing some music in the common area of his apartment block. And the guy on the fourth floor decided he didn't like how loud the music was, so he shot him with a shotgun. You can see how, because he was so far away, the bullets have kind of gone, or the pellets have gone in a wide spread, including his face and his thorax there. But unfortunately, even that can cause damage because one of them went in his eye and he ended up losing his sight. So it can still cause damage there. And then the most devastating one, this is a very close range one. You can see the person was trying to raise their arm to protect themselves and got shot in the arm. You can see the amount of damage that happened there. And when you get imaging on this, there's pellets everywhere. And if you do a thoracotomy on this patient, one of the challenges here is that there's so many different holes now that are there in the heart that make it a huge challenge to try and fix when these people arrest. So now that we know kind of some of the physics of bullets, then how do we change our outcomes? One of the biggest important lessons here is that penetrating trauma really, probably more so than any other trauma, is very time dependent. And so the earlier you can get interventions, the better. And inevitably, when any of these, either whether it's a mass casualty or a single shooting, there is a time period that happens from the incident happening to, if you work pre-hospital, getting to the scene, or any of the ambulance personnel getting to the scene to provide care. And so the public really needs to be given the empowerment to provide some care and some, basic first aid to these people while waiting for professionals to arrive. And we've seen the benefit of this in shootings like the one that happened in Las Vegas, like the bombing that happened at the Boston Marathon, where people who are there who have some first aid knowledge can turn into spontaneous responders. And so, understanding the importance of this, there's courses now that our medical specialty colleges have put together that will provide some basic first aid training for trauma to the lay public. And in addition, you can also use some of these geolocation apps that are available that have been used in cardiac arrest to try and get people who have training to the scene to provide some care. And similar to cardiac arrest, what we're seeing more and more in the States now is that we co-locate bleeding control kits that contain things like tourniquets or hemostatic gauze close to AEDs. And so the AEDs, we know they're beneficial for medical cardiac arrest. So we have all the life-saving equipment in one spot in the public space so that it's available for kind of any medical or traumatic problem. One of the big challenges with shootings is that, and for those of you that work pre-hospital, you'll know that they won't let you get to the scene, the police, because they'll say the scene's not safe. And so again, a time period passes where the person is injured, they could benefit from life-saving care, and so what do? You're not able to get in, so why not give the training to the police? And so more and more police teams have a trained medical person as part of their team that can go and provide care in that what's called the hot zone. And these can be paramedics, they can be physicians, depending on the team output, but they can provide care a little bit faster than until you wait for them to come into a safer area. And in Philadelphia, even we see that the police will often bring us patients. So they'll go to the scene of the shooting, and rather than having to wait for an ambulance to be able to come in, they'll just put the patient in the back of their car and just drive to our trauma center and bring the patients to us. So again, they save time by doing that. So that's another way that you can shorten the time to getting intervention done for these patients. Once they're with you, really important to find the holes quickly. And so if you follow this March approach, which I think all of you would be familiar with, one of the important things is that we need to expose the patient very, very quickly and look at them on all sides. And so as an example, you can see that this patient came in. They don't seem to have any type of injury on the front, but it's really until you roll them that you realize that this person's been shot in the buttocks. And so there's a huge amount of bleeding there, as you can see. One of the places, or two of the places that you really need to look at are the axilla and the groin. Those are places that wounds can hide, whether they're stabs or shooting. And also count the number of bullets, because you can sometimes figure out the trajectory by where the bullet holes are. So especially that's important if, say, one is in the abdomen and the other is in the chest. That means that both of those cavities might be injured. But if you're not sure where the trajectory is, using plain X-rays can be really useful to decide which cavity is important to manage first. And so, for example, this person was shot in the pelvis. You can see where the paper clip is. That marks where the bullet hole was. There was only one bullet hole. Can't see a bullet on the abdominal X-ray, but when you look at the chest X-ray, you'll see that the bullet's up above the diaphragm, causing a massive hemopneumothorax on that side, and they needed a chest tube being put in there. So once you've identified where the holes are, then you need to address the physiology appropriately and without delay. And this becomes a real question, how do I know that my patient is really in exsanguinating hemorrhagic shock? And I think this is certainly an easy question when you see that a person is bleeding out like this. But the ATLS has come out with these guidelines about different classes of shock. But I think many of you have seen papers that kind of dispute some of the benefits of using this classification. And so looking at signs and symptoms might be an easier way to identify who's truly in hemorrhagic shock and who do I need to really intervene on in a real quick fashion. And so various signs that you can see: altered mental status, really starting with even mild anxiety and confusion can be a sign of malperfusion. Hypotension, actual or relative, we always use this less than 90 millimeters of mercury as showing exsanguination. But remember, our patients are becoming more and more often geriatric patients, and so they can have baseline hypertension. So thinking about using a higher goal for them to delineate hemorrhagic shock is important. Relative bradycardia, so even though their heart rate might be high, if it's starting to come down, that can be a real sign of worsening hemorrhagic shock. Remember, in kids and older adults on multiple medications, there you need to take some care. This situation where they're yelling at you saying that I can't breathe. It might seem silly, especially maybe if they're shot in the belly, that they're saying they can't breathe. There's no chest injury, but this is really because they developed such profound metabolic acidosis that they're trying to breathe off that CO2. And that subjective dyspnea causes them to have that feeling that they're suffocating. And that's really an ominous sign that they are in profound shock. Diminished pulses for sure, but I also look at the patient's feet and I touch them. And that's often a good sign to show me whether this person is in real shock. If they're really pale in their feet, that can be a really important sign. And then end tidal CO2, as that's used as a trend, can be really useful to determine worsening shock as well. But I think our friends from London have really helped us look at cardiac rhythm as a way to determine outcomes in shock. They published a paper in JAMA recently looking at really two pathologies, cardiac tamponade and exsanguination, and looked at kind of the rhythms that happen for these patients. So they start off with sinus rhythm and rapidly then progress to a sinus bradycardia, broad complex rhythm, and then asystole. And all these are manifested as PEA arrest. And they found that really for cardiac tamponade, you have about 10 minutes or so to be able to intervene to still be able to get a good neurologic outcome. So you can see that if you identify that these patients have a tamponade and they're still in a narrow complex rhythm, their outcome is going to be pretty good if you react pretty quickly for these patients in arrest. Not so much for exsanguination. So exsanguination has a much shorter time window, about 5 to 7 minutes to be able to intervene. And certainly the earlier, while they're still in a narrow complex, they'll have a better outcome, but not quite as much time or as good numbers as for tamponade. And I'll give you just an example of how that can be practically used. So this was a patient that came to our center, shot in the legs, was in extremis. When they came in, you can see that they were in a sinus tachycardia, a little bit of sinus arrhythmia. They then started developing this relative bradycardia. So you can see the heart rate's still high, but kind of slowing down. Watch the end tidal as you go to a broader complex here. And then they briefly go into VFib and then a terminal kind of sinus bradycardia. And by the time really they were in that relative bradycardia was when they'd arrested clinically. And ultimately, this patient got a thoracotomy and was resuscitated. But because of probably we could have intervened, either here or here, because we intervened a little bit later, his neurologic outcome wasn't as great as it probably could have been. But this is an example of how that cardiac rhythm can help drive your decision making and your really the speed with which you progress to intervene. So we talked about kind of massive hemorrhage, other things to think about, tourniquets, hemostatic agents. We even have them in powder form as well. And we do use Reboa as well for some of our patients. But the next thing I really wanted to talk about was really emphasizing circulation while providing some basic airway support. And so certainly we don't want to rush to intubate these patients because if we take a hypotensive patient, we give them an induction agent to intubate them and then put them on positive pressure ventilation, that hypovolemic patient will arrest. And so really our emphasis needs to be on circulation. And so how do we address this? We get large bore IV access. If we can't get venous access, we'll go to intraosseous access, usually an IO in the humerus, but we also have sternal IOs that we use, and these have pretty decent flow rates for your initial resuscitation. These are available now if you guys want to look at it. And then ideally, we'll try and get a central line through a large bore introducer sheath in a vein that's above the diaphragm, so to be closer to the heart. We'll typically use whole blood as our resuscitation fluid. And we also are very particular about checking calcium early on. So we'll get a blood gas, and early on, we'll check the ionized calcium to replete that if it's low. About 50% of our patients tend to be hypocalcemic. And so one other thing that we've moved to early on, really to help guide the speed with which we need to resuscitate, is to try and get some central arterial access for invasive blood pressure monitoring. And that's really helped us kind of move forward quicker in our decision making to decide who's really sick and who's kind of a responder to resuscitation. Use your time efficiently. Certainly, we want to keep our time in the resuscitation room to a minimum. So we aim to try and do all these things within 10 minutes of the patient arriving because we have to decide at that point, does this patient need to go to the operating room or not? And then so that brings us, who needs to go to the operating room? And so if you look at different injury patterns, when you have limb injuries, then, if they have a fracture or a big vascular injury, then certainly they'll go to the operating room. But if they don't, then we often would just clean those wounds at the bedside and provide good wound care. For the chest injuries, we'll use our imaging, our physical exam to decide. Sometimes they'll need a chest drain or chest tube put in, and that can make our decision to go to the operating room pretty clear. But the one that are unclear is the torso injuries, so chest, so the abdomen and the pelvis. Certainly we'll interrogate these with our imaging and our physical exam. If we can get a CT, that's great. But an operating room question can be plus or minus. And this is really based on what we've learned from stabbings, because certainly a lot of patients with stabbings ended up getting laparotomies that were negative laparotomies. They have significant morbidity and length of stay issues associated with it. So we wanted to see whether we could use evidence that we've seen for stabbings, whether we can apply that for shootings as well. And certainly these criteria are great for stabbing patients, but for shooting patients, the challenge again is that temporary cavity. And so that can cause a lot more damage than with a stabbing penetrating injury. And so we want to be a little bit more careful with that. We want to think about patients that have all these criteria. So they have to be stable. They have to have no signs of peritonitis. They have to have negative imaging, and they have to be able to be re-examined by an experienced team to determine whether they actually need surgery or not. And so there is some evidence to support that for shootings. But what we don't know is how long we need to watch them for. If they have retroperitoneal injury, then they might not show signs of peritonitis. They might not have a positive FAST exam. And this is really useful for low velocity weapons. And certainly, if we have high velocity weapons, we can't manage those non-operatively. So there are some caveats with that. And then finally, I'll just touch on thoracotomy before handing it over to Rasmus, who'll talk more about this. But, how about ED thoracotomy? And certainly, we use kind of the criteria that have been laid out by various society guidelines. This is the Eastern Association for Surgery of Trauma guidelines, which highlight the need for thoracotomy. So certainly penetrating thoracic injuries will usually be the ones that get the thoracotomy to relieve a tamponade or to address any major bleeding in the thorax. Blunt resuscitation, blunt trauma, less so unless they have signs of life, which are listed at the bottom there. So these are our general criteria to kind of approach the thoracotomy. But I think the better and more relevant question to ask is who should do the resuscitative thoracotomy? And certainly, most people would say, especially our surgical colleagues will say, well, the surgeon's the one that should do the thoracotomy. And sure, if they're there, that's great. They can do the thoracotomy, and they'll probably have done more than us as emergency physicians will have done. But what if the surgeon's not there, or what if the surgeon is dealing with another patient? You might be at a smaller hospital where the surgeon is not there, or as we see often in the United States, even though I work at a level 1 trauma center where we have a surgeon 24/7, sometimes we get 3 patients come in at the same time who all need emergent intervention. And so the surgeon can only deal with one. So what do you do about the other? So and remember that time gap that we have. We don't have a lot of time to just wait for people to come and be able to do this. So what we decided, even at our level 1 trauma center, is that anyone who has undergone training will be able to do the thoracotomy. So here is a picture of actually me in the red cap doing a thoracotomy because my surgeon was up in the operating room. So we decided that if a patient needs a thoracotomy, then our emergency medicine faculty should be trained to be able to do that, or at least get it started until the surgeon can come and help us. And our main aim there is to relieve tamponade, to relieve a tension pneumothorax, and to cross-clamp the aorta. And we've undergone kind of some training program that I can answer about later. But certainly, it's really less a title and more thinking about your system and what works for your system and what's needed to proceed with having these skills to do. So hopefully that's given you kind of an overview about penetrating trauma and also kind of how we approach trauma in general in our center. I'll kind of stop there, and I don't know, Mohammed, if you want to take questions at the end or whether you want to have Rasmus take over here. I'll
Yeah, yeah,
I'll
exactly.
stop sharing.
Thank you very much, Zaf. Very well informative uh, s- talk. Yeah, I think maybe like the question, we leave it to the end. It will be better.
Okay.
Yes. So now we have our second speaker, Dr. Rasmus Strandmark. He's a specialist in emergency medicine who worked before in Sweden and now in Iceland. And he also completed his specialist training primarily at Mälarsjukhus in Sweden. And he has a lot of international placement in South Africa and Iceland. And he has a lot of good talks in USEM, the European Society for Emergency Medicine Congresses. I recommend you to watch together with Dr. Zaffer. Yes, Dr. Rasmus, the screen is yours.
Thank you so much for the invitation, and thank you, Zaffer, for your talk. Very informative indeed. So what I aim to talk about is what we do in the smaller trauma center. Just want to check that I'm currently sharing my screen.
Yes.
Okay, brilliant. Good. All right. So I won't be talking too much about gun injuries because we don't have a lot of that in Iceland. As you may or may not be aware, Iceland isn't very densely populated either. We're about 400,000 inhabitants, with an addition of 2 million tourists visiting each year. In fact, it's one of the most urbanized countries in Europe, but still the population usually doesn't live close to a hospital with surgical capabilities, at least not within 15 minutes. This is a map of the availability of such services over 60 or 30 minutes. The tourists tend to spend their time hiking up glaciers and climbing volcanoes and driving too fast on narrow gravel roads as far as physically possible from any type of healthcare institution. And the harsh climate and these facts sort of pose quite a significant challenge for our retrieval services. And all of this, of course, becomes a significant issue when you're dealing with traumatic cardiac arrests. Fortunately, as I said, Iceland is a quite peaceful country, so we don't see a lot of penetrating traumas at all. Most of our trauma load comes from road traffic collisions, tourists falling off the occasional cliff, and an increasing number of elderly people falling down stairs. Not having a high general trauma load and specifically not seeing too much penetrating trauma gives rise to the well-known problem of trying to maintain preparedness for something that doesn't happen much, but can happen at any time and will require your team's absolute maximum effort on an incredibly short time notice. And this is sort of the point that I want to address in my talk here. How do we work in centers that don't see a lot of traumatic cardiac arrests? How do we prepare? Let me start by giving you a bit of context on how our emergency department in Reykjavik works. Depending on the time of day, will be about 1 or 2, rarely 3 consultants on the floor. We usually have 1 or 2 senior residents with us and a few less experienced residents and interns as well. Our nursing staff is excellent, but like us, they're not regularly exposed to traumatic cardiac arrests. So they sometimes need more prompts and directions from the trauma leader. We typically have 1 anesthetist that can come down and assist. Surgeons are not available on short notice, although if we are pre-alerted about a peri-arrest trauma patients, we can sometimes get them in time to the ED to assist. So our trauma teams, they vary quite much in composition and experience. And for the emergency physician, the absence of a surgeon means the added pressure of being expected to perform procedures that are usually done by surgeons then in larger trauma centers. Most of the procedures needed, though, in traumatic cardiac arrests are core competencies of an emergency physician. So we can hold intubate, we can decompress the chest, we can put up large bore IVs and central accesses, we could do EFAST. So all of these things can obviously be quite challenging at times, but there's really only 1 or 2 procedures that are truly rare and uniquely challenging for an emergency physician. And that is, of course, thoracotomy, hysterotomy in those rare occasions. So apart from being able to perform our basic procedures, we also have to prepare to perform these two rare procedures if the indication presents itself and no one else is there to do it for us. On top of this, there's a third challenge of leading an ad hoc team that greatly varies in size, constitution, experience, and it's dynamic as well in terms of members being added as the case progresses. And the team is obviously working under immense pressure. So how do we prepare for this? It's not an easy thing to do, and I still feel that we have a long way to go in my center, but I will mention a few things that we are doing already and a few things that we're planning to do in the near future. The first thing is training. As part of our standard resuscitation training, we practice our time-sensitive basic procedures, like intubation, chest decompression, and different techniques to achieve IV accesses. To maintain readiness for rare emergency procedures, such as thoracotomy, we run annual live tissue training sessions using anesthetized sheep. There's a lot of sheep in Iceland, and these sessions allow hands-on practice on things like thoracotomy, surgical airway, vascular access, IV lines in live tissues. And I believe this adds a whole other dimension to one's understanding of the procedures. For these sessions, we do use sheep that have been models in different research projects and are now being euthanized. Once the sheep is anesthetized, but before they are euthanized, we are allowed access to practice these emergency procedures during that short time window. We're usually 4 doctors in each session to ensure that everyone gets some hands-on practice. For the rest of the year, we maintain regular simulation training. During these sessions, we try to identify areas where we need to improve. As an example, I tailored a simulation scenario to stress test our ability to activate and execute the massive transfusion protocol, which doesn't happen a lot. And I did this because I remember one session in my old ED in Eskilstuna, where I asked the lead trainer on the blood warmer to set it up as quickly as possible. And it took that person 10 minutes to achieve that. And as expected, we struggled as well in Reykjavik. Our massive transfusion is difficult to set up, and not all nurses feel comfortable doing it. And obviously, this is not a critique of anyone. These devices aren't as easy to set up as the manufacturers want us to believe. The point, of course, is when you're not regularly exposed to a procedure, and you suddenly have to do it under extreme pressure, that will be challenging for anyone. So we added this particular item to our reoccurring training. And that obviously leads us into the second topic, our equipment. The equipment must be easy to find. We saw the pictures from Zaffer Center, where you have these trolleys that you can move around. We've suffered a bit from having our equipment scattered in different places in the resource area. And some of it have even been kept in the storage room. So on repeat occasions, we've had to send people on excursions to get different items that we needed. And that's obviously not time that you want to spend during a cardiac arrest. So we've now tried to consolidate all relevant equipment into one trauma cart. This makes it then easy to move the equipment to the patient. It also gives you a bit of visual cues, looking onto the equipment to realize what you need to do. We keep airway stuff and IV accesses close in the resource area, but the rest of the trauma-specific equipment for thoracostomies and chest tubes and external hemorrhage control and such is kept in this chart. The third item to address is leadership. In terms of taking control over the situation and assuming leadership, we benefit from a culture shaped by many of our consultants being trained in Anglo-Saxon systems, where team leadership is emphasized. It's expected that a consultant will lead any resuscitation, and the team members are generally quite good followers. But despite this, we get ourselves into trouble on a regular basis, as anyone else. And taking charge under stress can be quite difficult. Sometimes the patients arrive without pre-alert, as you well know, or the situation deteriorates rapidly. And it helps, I find, enormously to have a prepared mental model, an on switch for leadership. I think most emergency physicians have that ability to switch that pattern recognition on and link it to a set action plan. I think it's helpful to do mental training, to simulate decision points and rehearse scenarios where there is no time to think or prepare, where you just need to start acting immediately. This saying is well known: under pressure, you don't rise to the occasion, you sink to the level of your training. I think that applies not only to procedures as such, but also to cognitive and leadership skills. We had a regular trauma case that I think illustrates this some. The patient was in shock, not in peri-arrest, had free fluid in the abdomen. You suspected pelvic fracture and a mangled left upper limb. We only had one IO in the right tibia coming from the pre-hospital setting, and we couldn't establish an access in the right arm. And no one was prepared for a central line. So the options were to keep trying in the right arm, prep for subclavian, or just move on with what we have. Doubtful if the patient would tolerate a CT without ongoing blood transfusion. Is it an option to go straight to theatre for damage control resuscitation? Sure that several alternatives are now popping up in your heads. And obviously that's great. Bringing those answers into your mental model is key to decreasing the risk of getting caught off guard when the unexpected happens. It's easy to assume that you'll always get IV access because it happens most of the times, but it doesn't happen always. Another assumption is that you can rely on your team to sort out all issues. In my experience, ad hoc teams in centers not regularly exposed to severe trauma have a hard time adapting when the situation deviates from the basic. As a trauma leader, you must then be prepared to help the team forward when things are not going as planned. So that's the three areas I think have the most impact on team performance in these smaller settings with a low frequency of traumatic cardiac arrests. Training the procedures to have your toolbox up to date and ready for use. Organizing your equipment in the way that makes sense to you, and mentally rehearsing scenarios with unexpected challenges and situations with no clear right or wrong answer, forcing yourself to make decisions. To end my talk, I would like to spend a few minutes just focusing on thoracotomy specifically, as it is a challenging procedure, not often performed. The way we prepare for this is, as I said, through annual live tissue training, being familiar with the equipment required and organizing it in a straightforward and accessible way, and through mentally preparing for making the decision to go ahead and do the procedure. Some of us have attended procedures course of some type to be able to learn the procedure from people with great experience and have to do and get the opportunity to train the procedure on cadavers. As it's difficult to dry simulate these procedures during the year, I revisit the video from my procedures course, 6 months or something like that, just to refresh memory. We keep a standard thoracotomy tray, and this obviously has the advantage that the thoracic surgeon will feel at home if and when they are available to do the procedure or assist. The downside is obviously that it's less intuitive for emergency physicians than a more strict setting. In addition, it helps, I feel, to include some radiopaque gauze and 2 large bore suction catheters and some other equipment. But the important thing is that you keep the equipment that you feel that you need to have to accomplish the tasks. Still, the decision-making is always the hardest, and this brings us back to the mental models. To build a model for decision-making on thoracotomy, one must know the capabilities of the team and oneself, what you and your team are trained for and capable of. Obviously, you need to check your equipment. Do you have everything that you need available to you? And you must be up to date with the current evidence on prognosis, because you will literally have no time to think this over when it's a live situation. Let's say that the ambulance delivers a blunt trauma patient with no signs of life for the past 15 minutes. Chances are obviously very, very slim for this patient. So this is not a patient that you want to perform a thoracotomy on. However, you might be in the situation where this particular patient is young and fit, has a clear tamponade on the EFAST, the heart is still beating, so it's a pseudo PEA, and there are no signs of any large bleeds on the primary survey. The survivability has certainly increased, but you need to sort of think this through and see what you are capable of doing and what your indication is in your center. And obviously, it helps knowing the factors that will influence your decision-making beforehand, knowing the data. Personally, I have sort of a hard time seeing myself doing a thoracotomy on anything else but tamponade. I feel confident that I can relieve a tamponade and make an honest attempt to stop the bleed inside the heart, but I'm not as confident that I could manage a massive hemothorax, for instance, with a large vessel bleed. I would be even more hesitant doing a thoracotomy simply to apply pressure on the aorta. I feel fairly confident that I could do it, but I'm less sure about what patient would benefit by it and how the rest of the team would be able to resuscitate the patient in order for the patient to benefit from it. Yeah, and this is the way one needs to mentally prepare, I think. Run over as many scenarios as possible, put yourself in tight spots by asking yourself difficult questions. I'm convinced that this is helpful when you have to make a split-second decision regarding whether to crack someone's chest open in the resource area of your emergency department. Thank you.
Thank you very much, Dr. Rasmus, for your amazing talk now. It's very informative for us, everyone here. Now maybe we can go to the questions. We have a lot of questions here. Some of them are directed to a specific doctor, but the other, maybe you can answer both. I don't know, you decide. So the first question is, I don't know if you guys can see it as well. It said, what do you think about the value of resuscitative thoracotomy in the hospitals that doesn't have a trauma surgical services, or its transfer to the nearby hospital is needed? So maybe I think, to Dr. Zaffer.
Great question. It's, and I think, later on somebody asked about a community hospital. So, I work at a level 1 trauma center, but I'd say the majority of the United States is living in areas where they don't have access to trauma centers within 60 minutes. And there's a huge portion where it's just the emergency physicians that are there. The surgeons are, they might be at home or something. And so, what do you do for these patients that show up that might benefit from a thoracotomy? And I think, you have to separate it from, oh, I'm an emergency physician and I can do this, or I should be able to do this, to how is the system set up to be able to care for this patient? And I think that's the important question to ask. So if you say that, for example, you're working at a community hospital that doesn't have immediate surgical capability, you have to think, okay, well, I'll open the chest. Okay, but then what? How do I get this person to a surgeon? It doesn't mean that you might not be able to do it, but before this patient has ever come to your hospital, you need to have had the discussion with either your surgeon in your hospital or with the referral hospital where you might send the patient to. If I meet this patient with this situation, then am I going to do with this? And if there is no way that the surgeon can get to that hospital in any kind of timely fashion, or that you can transfer that patient, should they survive, to a place that has surgical capability, then you are doing nobody any favors by doing the thoracotomy in that hospital, because who's going to take care of the patient afterwards? And so that it's less about the ability to do it is important, but it's much more important to have your system be able to be coordinated to do that. And that just means that, if you're determined that, you're going to see and take care of these people if they come in with a particular type of injury, it's certainly possible, but you need to have that system discussion that needs to be in place.
Thank you very
My
much.
short comment to that is just I think that the indication just narrows a bit, as you said, depending on whether or not you can transfer the patient or get a surgeon to you. But if you have a single stab wound in the chest, you're confident that you relieve the tamponade and put a finger on the bleed, then you could potentially transport that patient. But any other indication would be much more difficult. So yeah, it's definitely a local discussion you need to have.
Yeah, I agree with Rasmus as an emergency. Even in our trauma, so we decided that the things that we can relieve quickly are tension pneumothorax and tamponade, and those are the things that we would do if a surgeon wasn't there. And so and as emergency physicians, I think we get pretty good with ultrasound. So using ultrasound can be a really good technique to see whether, one, the heart is moving, and two, whether there's a tamponade that's caused them to arrest. And I think, if you have that information, then for that specific pathology, you can develop your system to address that particular pathology. And I think, you might have a survivor from that who will have benefited from you having that discussion beforehand.
Thank you very much, Dr. Zaff. The other question is, thanks for the talk. Super interesting. Two questions. Since your trauma bay are all open and numerous, how do you manage noise?
Yeah, it can be challenging sometimes when there is a lot of when there are people, multiple people coming in at once, and we just our nurses are great in being able to, like, our charge nurse will come and make sure that there's some noise control between the two things, and also part of the role of the team leader also is really important to make sure that there's discipline within that particular bay. And it's always, one of the other things that we sometimes struggle with is the person in one bay wants to see what's happening in the other bay. And so we have to be careful that, okay, you got one patient, you're focusing on this one person until we make sure that they're okay. So it just requires a lot of discipline. And part of what Rasmus was talking about being the team leader and kind of controlling the situation.
Perfect. And the other question is, how do you manage to have permission to record the resus with the cameras?
Yeah, that's an interesting thing because certainly it's it can be institution specific. So actually, our state laws allow us to use video for the purpose of either education or um, of quality improvement, and so, like, auditing. And so if we use it just for those two reasons, then we're allowed to use it. Our system is such that it's a continuous loop, so every 28 days the video gets taped over, and so there's no permanent record that's left. It doesn't go into the patient's chart or anything like that, and only a few people are given access to the video recording to be able to screen it. So we know exactly when they log in and when they log out, so that not everybody's accessing to it. And actually, the consent form for patients when they're admitted to the hospital includes that they may be videotaped or as part of their care. And so that's how our state regulations and laws allow us to use the video.
Thank you. And the other question is pre-hospital thoracotomy. Any updated on the numbers from the UK or any other experiences?
I don't have the numbers exactly. I know London in particular is probably at the forefront of doing it, but again, they do it because their system allows them to do it. And so I think the other places might suffer from volume or they might suffer from their systems issues, so they're not as commonly doing it. But I don't have the exact numbers. Rasmus, I don't know if you do.
No, not at the top of my head.
No. Perfect. And then we go to the next. In the community hospitals in the US and elsewhere, the ED physicians need to master all the aspects of trauma resuscitation. How is this prepared for the ED when the resident in the ED often rotate at the larger trauma centers in the US, working in the larger teams with many professionals?
Yeah, and I think a lot of it is, the stuff that Rasmus kind of talked about in his talk. We often will train in bigger centers and then send our trainees off to work in smaller centers. They might decide that they're going to work in smaller centers. And I think it all kind of boils down to, one, making sure that they physically can do the procedure. So there needs to be some sort of training, whether that's an animal lab or whether it's cadavers. We're lucky that we have access to cadavers that we take our trainees through. But some sort of, whether some form of tool that they learn, how to actually do the procedure. That's really important. But then, inevitably, even if you do thoracotomies, every day, if you have 30 people in your hospital, then the number of times that one person will do that will be pretty low. And so you have to use some of the tools that Rasmus talked about, mental preparation, thinking about reviewing videos. When you're sitting waiting for the next patient to come in, okay, let's spend 5 minutes talking about what if the next patient came in with a stab wound to the heart? What would you do? And then thinking about, okay, I'd do this for the procedure, I'd do this for the process, I'd do this. And I think there's real benefit in doing that because, as Rasmus said, one of the big challenges when you're working at a smaller center or even in a bigger center where you don't see these types of patients frequently is the inertia to act. So actually, in your mind, you're thinking, "Oh, I know, we should do a thoracotomy, but will I be able to do it? Should I do it? Should I not do it?" That hesitation is really difficult to get over unless you're doing something repeatedly. And, not everybody, thankfully is exposed to people who need thoracotomies every day, but you can talk about things. And by talking about things, then, your mind will know and see what needs to be done. And I think that shortens that time, that decision-making time. So I think there's real benefit in doing it. Even sometimes it sounds silly, oh, why are we talking about this if we'll never see a patient, or maybe once a year we'll see this patient. But when once a year that patient comes, you've talked about it. Your team is then ready to act when that happens. And so there's real benefit in doing that. And the other thing is that we always focus on our trainees, which is really important, of course. But sometimes we forget that, once we become consultants or attendings, then we also need to refresh ourselves. And so part of our culture has changed in the last few years that we do separate kind of procedure day where we go through procedures just with our consultants. And so it lets our consultants kind of have that psychological safety that they're not being judged by, say, a resident or something, but also then gives them the chance to refresh something they may have not done in a couple of years or something. So I think there's a huge amount of benefit in mental modeling, in simple task trainers, and then talking with your team members about how you would approach a patient.
Thank you, Dr. Sav. The question to you as well, again, how do you prepare the junior doctors in the trauma procedures, or rather, how do you know when the physician is ready to perform the procedure? Do you train as a team or as individuals?
Yeah, I think really important to train as teams because and some of our video work is really to see how the teams work together. And so I think it's because it's also the system, how the system takes care of it. While you're doing the procedure, Somebody needs to be starting the blood. Somebody needs to be thinking about what to do for the airway. Somebody needs to be leading the resuscitation. So thinking about, that team part of it is really important. How do you know when someone is ready, I think is a very difficult question, and not just for kind of trauma resuscitation, but also in training in general. I think, you get some trainees who just need to do a procedure 5 times and they're very good at it, and some people need to do it 15 times and then they're good at it. And I think, as a trainer, I find it difficult sometimes to figure out what the threshold is, that they say that they're actually trained. And I would say that as a trainee, you have to be honest with yourself to say, I feel confident about it or I don't, and I need a little bit more time to do this, I think. And I think, we need to let our trainees be able to say that I just don't feel that I've gotten this right, or this part of the procedure I don't get, and could you take me through it one more time? And I think that needs to be individualized for our trainees.
Thank you, Dr. Zaff. A question to Rasmus. Thank you for sharing your experience about the challenges in executing time-sensitive resuscitative processes, like massive transfusion protocol when it's not in a high-frequency use or when there isn't a regular training. Practice across all the discipline, medicine, nursing, labs. I have had a similar experience as an emergency physician in Australia when working in a trauma center in Sydney. Where the massive trauma transfusion protocol was regularly used and efficiently, whereas at more peripheral centers and peripheral hospitals, we have come into trouble. A regional trauma service meeting, this has been identified. Great idea with SIM training.
Yeah, it's just about exposing your weaknesses in your team performance. And I think you should sometimes use simulation to enforce good behavior, but sometimes you should also stress test the system to see where you could improve. And massive transfusion protocol is definitely one thing smaller centers struggle with, I would say, but there's several more hidden gems there that you could expose with simulation.
Yeah, it's a great point. At one of our smaller centers, we were trying to revamp how they did their massive transfer, and we thought, there seems to be this delay for getting the blood. What's the delay? What's the delay? And actually, with the simulation, we figured out that it was, the unknown patient comes in, the fact that they're not registered properly and have a number for the blood bank to use to release the blood was the delay point. And you wouldn't know that unless you got the whole team involved and got involved. And once we figured that out, then we were actually very fast in being able to get blood to our patients. So it's those little things sometimes that can be big barriers, and simulation can be really useful for that.
Thank you, Dr. Sav. And question again to Rasmus. Is it economically efficient or time well spent to train and prepare a system for a very, very rare procedure, like a halo procedures or whatever? How do you tell your boss that it is important to have a system that is prepared for these situations?
Yeah, that I think I struggle with this question because, okay, but more generally, most of the time, for thoracotomy to me is quite it's quite stringent. The indication for it, the cost isn't very high. We keep a tray that is sort of shifted every once in a while to keep sterility. The training doesn't cost particularly much. So for that readiness, I just use the ethics of my own practice. Like I ask myself, what if my own daughter was stabbed in the heart and the physician that met her would not perform this procedure? I would be furious, if the indication is there. So I just use that to justify this training that I sort of personally keep up to date, but the cost isn't huge. But the question is relevant in many instances of very expensive care that we provide to patients.
Thank you, Dr. Rasmus. And we have a message from Therese Järv. She is the council. She's a chair in the Swedish Resuscitation Council, and she said that you are both wise.
Thank you very much.
I have a question for you, Sab.
Lucky to have good mentors and teachers, I think.
Thank you. I just, I listened to your podcast about the peri-arrest and traumatic cardiac arrest. And then I went to the paper that you published together with Luca Carenzo from Italy. And like how to think out of the box, you know, while you're managing the cardiac arrest. So I will share it to our group so we can maybe see it and think about it. But I have some questions regarding this. You know, like when you decide that you have a traumatic cardiac arrest, what do you do? Like which steps? Because I know we was trying to move from the 4H and the 4Ts to the HOT that you prescribed in your paper. So can you just speak a little bit about it, like quickly, as well as the rule of chest compressions? Because what we have in our guidelines, like that you do the resuscitative CPR together with the HOT that you do.
Yeah.
So can you just
So the HOT approach, so HOTT, is kind of looking at things that can cause traumatic arrest. So first and foremost, H is for hemorrhage, and so addressing hemorrhage, whether that's compressible in particular, so you know, putting a tourniquet on, packing wounds, those kind of things. You have to stop the hemorrhage, and in that, along with the hemorrhage, replacing what's lost. So which kind of comes a little bit later in one of the T's, but kind of thinking about transfusing as well. Next is oxygenation. So hypoxia can cause the arrest to happen, but you don't have to necessarily intubate. You can even put in I-gel or supraglottic device temporarily, bag valve mask technique while you address the other things. Next is tension pneumothorax. So if you're unsure whether, you know, and especially if you have a chest trauma, whether it's blunt or penetrating, decompress both sides of the chest. I don't like using needles. I don't think they're very effective. And so I will favor doing open or finger thoracostomy. So essentially just making all the steps for chest tube placement except for putting the chest tube in. And then the next T is transfusion. So transfuse blood, ideally. These patients are bleeding, so they need blood. So those are the main kind of steps that you can approach to doing it. The next one, if you have the skills like we talked about, you know, and that injury is amenable, then you do a thoracotomy. And so that's the last T. So HOTTT makes HOT. The next question was about chest compression. So, you know, we're kind of in our culture, you know, we see more medical cardiac arrest than we see traumatic arrest. So our nature is to, if someone's heart stops beating, that we start chest compressions. But in trauma, remember, there's two things mainly that are going to cause people to arrest. First and foremost, number 1, 2, and 3 are going to be hemorrhage. And then it might be an obstructive pathology like tamponade or tension pneumothorax. And so if you think about it, you know, in medical cardiac arrest, what happens is that the person has like an MI, they have a, you know, a coronary vessel occlusion, their heart pump stops working. But in traumatic arrest, usually the pump is still trying to do something. But the problem is that either there's nothing to pump because they've bled out, or it's pumping against an obstruction, so the tamponade or the tension pneumothorax. So by doing chest compressions, you're not helping any of those problems. In fact, you might delay the life-saving thing that you need to do, which is either the open thoracostomy or even a thoracotomy if you need to. But you know, if say Rasmus is standing there doing chest compressions and I'm wanting to bring a knife to the skin, I'll be worried that I'll hurt Rasmus and while I'm trying to do that. So you're actually delaying care by doing the chest compressions, which in this instance is not helping the patient with their pathology. And so that's why I say, you know, for traumatic arrest, if you have the skills and you understand the pathophysiology, address the pathophysiology first, rather than doing chest compressions in those patients.
Thank you very much, Dr. Zaf. I don't think we have any more questions now because now we are 15 minutes late. So I'm really sorry, like to take your time both.
No, that's good. All right.
If there's something that you want to add, Dr. Zaf.
No, I just want to say, real thanks for the invitation to be here. I'm going to put my email in the chat. So in case anybody has any other questions, I'm happy for you to reach out to me. And, I'm really, it's an honor for me to talk to you guys. And, I really, education and learning is one of my passions. So if I can help your next patient in any way, or even your thinking in any way, then I feel that that's really beneficial for me as well to be able to help you guys. So thank you so much.
And we're looking forward to invite you to Sweden as well again, but
Yeah,
not in
yeah.
Örebro this time, maybe in Stockholm.
Oh, and in the summer, please.
Absolutely. Absolutely. Yes. Dr. Rasmus, do you have something to add for us?
No, I think it was really good listening to Zaf as well, to get sort of the latest from the bigger centers. Is always good to keep up to date. And I mean, a lot of the things that we talked about should have relevance to the Swedish discussion as well, on what the sort of the scope of practice for emergency physicians are, and how we shape the specialty in Sweden. So it's always nice to expand the boundaries of how we think on that. I'm pleased to be invited and talk to you guys about it.
Thank you very much, both of you guys. And on the behalf of the SWESEM Learning, we want to extend our heartfelt thank you to both of you. And we hope to see you again, maybe in other few topics. Have a nice evening.
Thank you so much.
Thank you very much. Take care. Bye-bye.
Bye-bye.